Welcome to MED-MYSTIFY. Today, we're opening up the ultimate medical toolbox. We're going to completely demystify the complex world of antihypertensive agents. Look, if you've ever stared at a massive list of blood pressure medications and felt, totally overwhelmed, well, you're absolutely in the right place. We're breaking down the complete classification guide for these drugs, and we're going to make it logical, visual, and most importantly, highly memorable.
Okay, let's dive into this. Here is our explainer roadmap for today. We'll start with understanding hypertension, then open up the anti-hypertensive toolbox. After that, we'll walk through the major drug classes: ACE inhibitors and ARBs, calcium blockers and diuretics, adrenergic and ganglion blockers, and we will wrap it all up with vasodilators and next steps. Section 1. Understanding hypertension. Before we can start pulling tools out of our medical toolbox, we really need to understand the exact problem we're trying to fix here. At its core, hypertension, or high blood pressure, is defined as a chronic cardiovascular disorder characterized by a persistent elevation of arterial blood pressure. Now, the absolutely crucial words here are chronic and persistent, right? This isn't just a temporary blood pressure spike because you had a stressful day at work. This is a sustained, ongoing pressure inside the arterial walls that literally demands intervention. So what's the number? The traditional threshold for this persistent elevation is a blood pressure of greater than or equal to 140/90 millimeters of mercury. I really want you to anchor that traditional criteria in your mind, but just as a quick side note, current guidelines might actually define it at lower values depending on which specific medical organization you're looking at.
This brings us to why we even need these medications in the first place. If left untreated, the stakes of this persistent pressure are incredibly high. It's a major risk factor for a whole cascade of life-threatening conditions. We're talking about stroke, myocardial infarction, which is a heart attack, heart failure, chronic kidney disease, peripheral arterial disease, and even retinopathy in the eyes. It is a massive systemic threat, which is exactly why our pharmacological toolbox is just so vital.
And that brings us to Section 2, the Anti-Hypertensive Toolbox. Let's officially open it up and take a look inside.
So how do these medications actually accomplish their goal? Think of your cardiovascular system like a closed plumbing system. To lower the pressure inside those pipes, these drugs essentially do one or more of four things. Number one, they decrease cardiac output, basically slowing down the pump itself. Number two, they reduce peripheral vascular resistance, which is kind of like physically widening the pipes. Number three, they decrease blood volume, essentially draining some fluid right out of the system. And number four, they inhibit specific neurohormonal pathways, specifically the RAS pathway, which acts as a master control switch for blood pressure.
But here's the thing, we don't just reach in and blindly grab a tool. The specific drug choice relies heavily on four very distinct patient-specific factors. We have to look at the patient's age, any associated diseases they might be dealing with, the sheer severity of their hypertension, and whether there are any complications present. It's a highly tailored approach.
Moving right along to Section 3, ACE inhibitors and ARBs. These are our first major drug categories, and they specifically target that neurohormonal RAS pathway we were just talking about.
Okay, pay close attention here, because I'm going to share a massive pharmacy study hack with you. Memorizing these lists can honestly feel like a nightmare, but you just need to look at the common suffixes. For ACE inhibitors, notice how they almost all end in that distinct pril sound. We've got captopril, enalapril, lisinopril, then ramipril, perindopril, fosinapril, and finally trandolapril, quinapril, and benazepril. If you see a pril, instantly think AC inhibitor. Then right below that, we have the ARBs. Their secret weapon for memorization, the suffix sartan. Losartan, candesartan, valsartan, eprasartan, and irbesartan. Once you recognize these suffixes, memorization becomes an absolute breeze.
All right, Section 4. Let's grab the next set of tools in our anti-hypertensive toolbox: calcium channel blockers and diuretics. So here's our list of calcium channel blockers, and guess what? We've got another brilliant memory trick for you. Read through the list with me: nifedipine, nicardipine, nimodipine, amlodipine, felodipine. Notice a pattern? The vast majority of these drugs share the suffix dipine. Now, the major standout exception in this group is verapamil, so definitely lock away dipine in your brain for calcium channel blockers, but keep verapamil off to the side as your one big exception to the rule.
Next up, diuretics. These primarily help by decreasing that blood volume we talked about earlier. Now, this is a pretty complex class, but we can easily break it down into three distinct subcategories. First, we have the thiazides, which include hydrochlorothiazide, chlorthalidone, and indapamide. Second are the loop diuretics. These feature heavy hitters like furosemide along with bumetanide and torsemide. And third, we have the potassium-sparing diuretics, with examples like spironolactone, amiloride, and triamterene. By just breaking them down into these three simple buckets, it makes them way easier to categorize in your mind.
Let's keep this momentum going. Section 5, Adrenergic and Ganglion Blockers. This section deals heavily with the nervous system's direct role in controlling blood pressure.
Now, the Adrenergic Drugs class is incredibly dense, so let's clearly contrast the first two subclasses so they're easier to digest. On one side, we have centrally acting drugs. These actually work all the way up in the brain and include clonidine, methyldopa, guanabens, and guanfacine. Contrasting those, we have the adrenergic neuron blockers, which work a little bit differently, and those include drugs like guanethetidine and reserpine. Keeping these categories strictly separated in your head is the key to really mastering this classification.
Okay, for the third subclass of adrenergic drugs, the sympatholytics, I'm going to share yet another incredible study hack. Check out the alpha blockers. They heavily feature the suffix zosin, prazlosin, terazosin, and doxazin. Though, heads up, you do still need to remember phenoxybenzamine and phentylamine. Then, look at the beta blockers. Their magic suffix is olol. We're talking propranolol, atenolol, esmolol, and metoprolol. Finally, the drugs that block both alpha and beta receptors use a blended sound, alol or illol, like labetalol and carvedilol. Using these suffixes literally takes an intimidating, massive list and makes it so approachable.
Moving on to class number 6 in our primary list, we have the ganglion blockers. And for this one, we currently just have one solitary drug listed to remember: trimethophan. Super short, sweet, and easy to file away. And just like that, we've made it to the final section of our breakdown. Section 6, Vasodilators and Next Steps. Let's check out the final tool in our toolbox before we set up a pretty major cliffhanger. So, vasodilators are drugs that directly relax the smooth muscle in your blood vessels. But we really need to differentiate between two specific types here. On one hand, we have arteriolar dilators, which specifically target the arteriolars, the small arteries. Examples here are hydralazine, minoxidil, and dioxoxide. On the other hand, we have a drug that casts a much wider net, sodium nitroprusside. This one is an arteriolar and venular dilator, meaning it targets both the arteriolars and the small veins, or venules. Knowing exactly where these dilators act is an absolutely critical distinction.
All right, we have successfully categorized the entire toolbox. We know the names, we know the classes, and we've got the suffix hacks to remember them all. But this brings up the ultimate question. How exactly do all 7 of these drug classes actually work on a molecular level inside the body? What is their specific mechanism of action? Well, that is a massive topic for part 2. Like, subscribe, and share this with your friends for such more pharmacy-related informative videos. Be sure to write your questions, suggestions, and thoughts in the comments section. We will catch you in next one.